Welcome everyone to the first webinar of InTune. And InTune is a program that we are developing stemming out of UCL, University College London, where we want to make sure everyone is educated and supported around menopause. And the InTune team are myself, Shema, Tariq, and Nicky, Keay, who are joining us on the webinar today. And we've also got Florrie and Polly, who are our excellent team. So without further ado, World Menopause Day is on Friday, and the theme is Understanding Hormone Replacement Therapy, or HRT. So we have got 4 brilliant speakers. Now, because we're global today, we've got Susan Davis, who's a testosterone expert, and she is in Australia. And we've got Jen Gunter, who is a wonderful, controversial doctor, who I'm sure is going to give us an excellent talk, but she's in the USA. So we had to give somewhere. So Susan has pre-recorded her talk, and I'll play that for you today. Jen is going to come on in 30 minutes. It's going to be 6 a.m. where she is. So I've told her just to come and join us then. So welcome, everybody. Thank you so much for attending. And I'm going to hand over to Shema now to introduce our first speaker.
Thanks, Joyce. Thanks to everybody who's joined us, and thanks also to our panelists. I'm really, really excited about today's session. So I am delighted to introduce my colleague, Dr. Vikram Talaulikar. Vikram is an associate specialist at the Reproductive Medicine Unit at UCL, University College London Hospitals NHS Foundation Trust. He's also an honorary associate professor at UCL. He runs a busy menopause and PCOS clinic at UCLH and a menopause clinic and the Menopause Clinic London on Harley Street. He's also an extremely important source of advice and input into the HIV and menopause service that I run at Mortimer Market Centre. So over to you, Vikram.
Thank you. Thank you, Shema. Thank you, Joyce. Thank you, Nicky. First of all, for putting together this excellent program, InTune, as it sounds. And thank you for the invite today to present. Now, it's a packed program, and I know it will be me, Juliet, and Susan and Jen, one after the other. And we have 10 to 12 minutes each. So I'm not going to waste any more time. Go to share my slides straight away. But welcome everyone who has given us your time today. So sharing my slides now, and you should be able to see them straight away. And just tell me if you can see them.
All good.
All good. Good. I'm going to go to slideshow, play from start. There it is. So the theme, as Joyce said, it's HRT, hormone replacement therapy, widely also known across the world as menopausal hormone therapy, or MHT. And what it is, it's basically replacement of hormones which tend to decrease during menopausal transition. So before we get to the nitty-gritties of HRT per se, a quick sort of background about what happens during the menopause journey. So before any changes to hormones start, it's premenopause. This is when most women, individuals, will be having regular menstrual cycles with no symptoms. Then comes the perimenopause. This is when hormones start fluctuating for the first time. The FSH, LH, estrogen will go up and down. Most women will notice changes to their periods. Some may start noticing some symptoms. And perimenopause usually will hit most women between 40 to 50, but it may be variable. For example, some women may have few months or years of perimenopause. Others might continue for 5 to 10 years or longer. Then comes menopause. This is a retrospective diagnosis. Once periods stop for 1 year, that's when we say somebody has attained menopause. It's 1 year since the last menstrual period. And then postmenopause is anywhere from that point on, 1 year since the last period until end of life. And that could be 20, 30, 40, 50 years of a woman's life, which is why we are focusing on this aspect, that we want women to have good quality of life and protect their long-term health during those 20, 30, 40 years. It can be different experience for some individuals who have medically induced or surgically induced menopause. That can be a bit abrupt, especially following surgery or cancer treatments, and the symptoms may be more severe or persistent, but we'll hopefully catch up with that during the question-answer session. Important to know, every woman's menopause journey is different. You may have some who may have minimal or mild symptoms for a few months or years. Others may have quite severe debilitating symptoms, which may go on for 10, 15 years or longer. So again, the experience with HRT can differ, and it's individualizing that is most important. Timing of menopause. Age of onset of menopause in the Western world is around 51, which we consider as an average, but it can happen anywhere between 45 to 55. That's the natural age range for menopause. 10% of women will have it between 40 to 45, and that's early menopause. 1 to 2% will have it below the age of 40, sometimes even below the age of 30, and that's premature menopause, technically also known as premature ovarian insufficiency. Ethnicity, socioeconomic factor, genes all make a difference to onset of menopause. So Southeast Asian women, for example, may have it 4 or 5 years earlier, as average age at 46 or 47. Afro-Caribbean women may have it 1 or 2 years earlier. We need much more data on this, but it does look like ethnicity plays a very important role. Diagnosis of menopause is based on symptoms and menstrual cycles. Very little input from blood tests, especially if somebody above the age of 45, you don't need routine blood tests to diagnose menopause, and interventions could be offered to improve quality of life without blood tests. Blood tests will be important for somebody below the age of 40 to make sure the diagnosis of POI is correct. Symptoms of menopause transition can be from head to toe, can start with headaches, brain fog, low energy, can be hot flashes, night sweats, sleep problems, which are classical symptoms. Could affect the skin, joint pains could be another. Irregular periods are common during perimenopause. Local symptoms can be vaginal dryness, painful sex, libido can be affected. And then, of course, psychological symptoms should not be overlooked: low mood, heightened anxiety, palpitations. Now, I've enlisted the common ones, but of course, everybody will have a different set of symptoms. Some may have minimal, others may have multiple severe symptoms. There are also changes happening in the background. It's not just the symptoms affecting quality of life. It could be changes to lipids. So for example, the unfavorable cholesterol goes up, the LDL cholesterol increases, body fat distribution changes. So often there is central fat distribution. There is a little bit of insulin resistance happening at the same time. Bone turnover changes. So women tend to lose a bit of bone density, and coagulation and fibrinolysis, which means the blood clotting profile can change slightly. Now, again, this is not a scare story. Women will have these changes as part of aging as well, and hormones may contribute variably depending on which women are more sensitive to particular changes to particular tissues and organs. So just to keep in mind that there are some changes happening along with aging, side-by-side hormonal changes. Let's get to the nitty-gritty. What is HRT now? So it's replacing estrogen, progesterone. That's the traditional part of HRT. Some women now also include testosterone. That's primarily prescribed for the indication of persistent low libido. And Professor Davis is going to talk a lot about this after I and Juliet finish. So I'm going to skip that. Local vaginal estrogen can be local HRT, and systemic HRT is in the form of tablets, patches, gels, which basically affect the whole body. Systemic HRT, or estrogen replacement as part of HRT, remains the most effective medical treatment for menopausal vasomotor symptoms which affect quality of life. There were problems with HRT some while ago when some of the studies were published. These are the newspaper headlines around 2000 to 2003, 20 years ago, when the big trials from US, WHI, and from UK, the Million Women study were published. It did give an impression that women had a significant increased risk of breast cancer, stroke, and heart disease. HRT prescribing declined after this because both women and the health professionals were worried. But thereafter came the NICE guidelines around 2015. They re-looked at some of the results that were published, as well as they had more studies to look at in the 15 years that had passed, and they found that some of the dangers had been exaggerated. So the NICE guidelines did recommend for majority of women who are suffering from symptoms, they can use HRT and the benefits will outweigh risk. That doesn't mean everyone wants to take HRT or wishes to go on HRT. It's an individual choice depending on benefits and risk. What are the kind of HRTs that we talk about in the modern world? So you have choice of various preparations. More than 40 preparations are available in the UK. The ones that we like are estrogen, which is more body identical, like natural hormone. It's called 17-beta estradiol, which is widely used on the NHS and in the private sector. Progesterone is a natural progesterone or the dydrogesterone, which are two body-friendly versions. These have now largely replaced the older progestrogens, which are the norethisterone or the Provera, or because these are less androgenic, cause less side effect, cause less blood clots and impact on the breast. Some women, 10 to 20%, have progestogen sensitivity. They don't tolerate progestogen well in HRT. So you might have to be careful about the dose, route, and frequency. What about routes of HRT? You have tablets, you have patches, gel, spray, implants, you have vaginal estrogen, cream, pessary, ring. You also have the Mirena coil, and everyone will be given the options depending on their particular symptoms and their medical history. Estrogen is the key hormone, suppresses the symptoms, improves quality of life. It protects the bones and the heart, especially if you start it early, below the age of 60 or within 10 years of menopause. It can have some minor temporary side effects like headaches, breast tenderness, nausea, or breakthrough bleeding. But generally, estrogen alone will be given to women who've had a hysterectomy, while those who have a womb will get estrogen along with progesterone. Let's look at the progesterone. It's the necessary hormone. It's combined with estrogen because it's protecting the lining of the womb. Estrogen alone can cause it to thicken. It has got side effects such as bloating, mood change, breast pain, but generally you can find a preparation that works for most women. On its own, it can help with flushes and sleep, but the breast cancer link of HRT comes from this hormone and not the estrogen. Looking at contraindications, I'm not going to go through the details. Anybody with breast cancer, estrogen-dependent cancer, undiagnosed bleeding or blood clotting problems, always important to see a specialist clinic because in these conditions, HRT could be dangerous, could be not recommended, or if you have to take it, you need specialist input. Some women take cyclical HRT, which means in perimenopause, early menopause, it's good to have a cyclical bleed to avoid breakthrough bleeding, while women who have been more than 2 years into menopause will go for bleed-free continuous HRT. A quick word about vaginal estrogen. They are very effective for dryness and painful sex. They can reduce frequency of urinary infections, also help with incontinence symptoms and pelvic floor muscle. So these are very suitable in women. You can use as long as required because they are not absorbed into the systemic circulation as much. And even some women with breast cancer who have terrible vaginal symptoms could take vaginal estrogens through specialist input. Finally, last few slides, 2 or 3, HRT risk. Any benefits of HRT for bones, for metabolism, for heart, and for symptoms and quality of life always need to be balanced against the minor side effects we talked about and the risk. And there are 4 risks that we talk about. Risk of stroke or thrombosis, very low risk with oral HRT, but no risk usually with transdermal gels or patches. So it's quite safe to use the gels or patches. They wouldn't increase the risk unless you have a background medical condition. Endometrial cancer, if you have enough progestogen and you're not taking too high unlicensed doses of estrogen, then generally the progestogen will give protection against endometrial cancer. So it's important to know that you're on the right dose combination. Breast cancer risk does exist. Any woman taking a combined estrogen progestogen HRT will have a 5 in 1,000, about 0.5% extra risk of breast cancer over a period of 5 years. That needs to be balanced against the benefits. And finally, heart disease. If you start HRT early below 60, it's usually beneficial, reduces risk of heart disease. After 60 though, or after 10 years of menopause, it's neutral. So it will not give particular benefits, but it may not also increase any serious events cardiac-wise. That was just a quick graph to show you that the risk of HRT is about 5 in 1,000 for breast cancer, and it's more or less similar to contraceptive pill. Other things like drinking 2 or more units of alcohol, smoking, or obesity have a much higher risk bearing on the risk of breast cancer. So lifestyle is critical. Even if you're choosing HRT for your symptom, it's really important to focus on lifestyle in the background, which will add to the protection. HRT can be used long-term now. It can be used from perimenopause right up to something like 70s or 80s or even lifelong for some women. We don't have good data, long data after 65. So we have to be careful balancing the benefits and risk. There's no upper age limit arbitrarily, but it's an individual choice and a decision between the doctor and the patient. Most women use it for 5 to 15 years, slowly wean off, and then stop after a point. So with that, I'll finish my presentation, whistle stop tour, hopefully lots of questions at the end. Over to the next speaker. Thank you.
Vikram,
Thank you, Vikram.
Thank you so much. That was an incredible tour de force on HRT. Joyce, I think I'm handing over to you next to introduce our next speaker. Is that right?
Yes, thank you, Shema. And yes, I forgot to say, I think some people have found it. We're just using the Q&A today. So if you've got any questions for any of the speakers, I can see a few questions coming in. Please put them in. So it's a real pleasure to play the recording that I did last week with Professor Susan Davis, who is a clinical researcher with expertise in the role of sex hormones in women across the lifespan. And she is considered an international authority on androgens, which is things like testosterone, in women and the menopause. So it's absolutely, she's the perfect person to talk to us about testosterone. And I know it's a very controversial topic with so many women thinking it's going to give them more energy and do lots of other things.
My name's Professor Susan Davis. I'm an endocrinologist, and on World Menopause Day is a great time to reflect on menopause and its treatment. So while I'm mostly going to talk about testosterone, I think it's good to see the history of where we're at now. So in the 1980s, when I started in this space 40 years ago, nobody really talked much about menopause and we didn't have many treatment options. By the 1990s, there was so much enthusiasm about hormone replacement therapy, we were even considering it would prevent every disease. Prevent heart disease, prevent dementia, keep women young, everybody should be on it. The Women's Health Initiative was a big wake-up call. The study that came out in 2002 that warned us that HRT might cause breast cancer. Now, I know a lot of that has been reviewed and a lot of the anxiety has been dispelled, and the risks aren't nearly as bad as we thought. But we did learn a lot from that study, and it does have some red flags that we need to be cautious. What is alarming today is that people have come out of the woodwork and self-proclaimed themselves as menopause experts. They're prescribing doses of estrogen and progesterone that we have never seen before, that have never been studied. And while we'd got to a point where we were talking about menopause again, and probably quite safely prescribing estrogen, the pendulum is swinging even further so that women are getting such high doses that we really do not know if perhaps they're going to be at risk of breast cancer and uterine cancer. So I do caution women to be a little bit reflective over the doses they're getting and thinking about whether they really need to try using some more conservative doses and not believe a lot of the misinformation that's out there on the internet. So the evidence that estrogen will prevent heart disease in most women or prevent dementia or improve cognition is simply lacking. But what about testosterone? Well, my research group has probably done the most research on testosterone as any group in the world. We've published the major studies looking at testosterone in women, from sexual function through to heart disease risk through to cognitive performance and muscle function. And I can assure women that the only evidence for the use of testosterone is for the treatment of postmenopausal women who have a lessened libido compared to their previous years and for whom that is a concern. There is absolutely no consistent evidence that testosterone therapy will improve cognitive function, prevent dementia, prevent heart disease, or even improve well-being and vitality. Why do I say this so dogmatically? Firstly, because I know the literature inside out. I could cherry pick studies and show data that would suggest testosterone has specific benefits. But then you've got to balance up all the data. And if you balance up all the studies, there is absolutely no consistent evidence of benefit other than sexual function. We've done studies looking at well-being. A A lot of my patients over the years told me that their well-being improved on testosterone. Great. I'm really happy for that. But when we've compared to testosterone with placebo in studies of hundreds of women, we've found that testosterone was no more effective on improving well-being compared to placebo medication. So if you're paying a lot of money for a treatment, or if you're using a treatment every day, and you've got a doctor who is prescribing this that is very enthusiastic and encouraging, it is highly likely that even if you had placebo cream, you would benefit. I'm not particularly concerned about harms of testosterone, although there is a harm if you are paying a lot of money for a treatment that does not work. And there is a harm if you're treating a symptom with testosterone that is unlikely to improve and you're missing out on proper treatment. Testosterone should not be used to treat depression. There are studies showing that testosterone does not improve depressive symptoms and it does not improve depression in women. You should not use testosterone to prevent bone loss. We have done a study that suggests that testosterone may improve bone density. Other studies have shown no benefit. So if you're using testosterone to prevent bone loss, you may be missing out on using an effective treatment for bone loss that is not testosterone. You also need to be careful about things like believing it will improve cognitive function, which I've mentioned, and it's not a treatment to prevent dementia, as I've said. Every woman does not need testosterone. In fact, most women don't need testosterone as a therapy. And we don't treat low testosterone, we treat symptoms. If your doctor said, oh, I've checked your blood and your testosterone is low, that is not really a concern. This is for two reasons. Firstly, the blood tests that we have are useless in distinguishing normal from low from very low. Unless you're going to a highly specialized laboratory having a unique whiz-bang technical blood test, the standard blood tests are useless at the low levels that we see in women. Secondly, low testosterone doesn't mean anything. We don't know that low testosterone is significant. Our research using very sensitive measures of testosterone have not found that women with lower levels have more symptoms of any particular kind than other women. So there is no condition of androgen deficiency, and there's no evidence that any symptoms align with low testosterone. So plenty of women with low testosterone have normal libido, and plenty of women with high testosterone, for example, have low libido. So in summary, don't be misled by a whole lot of highly convincing people on Instagram and YouTube who are telling you you need hormones when in fact you possibly don't. Go and see a NHS GP experienced in general medicine and menopause and get some really good, genuine care. Happy Menopause Day.
So without further ado, that perfectly segues into our next speaker. I'll hand back over to you, Shema.
Thanks, Joyce. That was fantastic to hear Susan talk so eloquently about testosterone, which I think many of us who are working clinically will be inundated with questions about testosterone. So really great to now hand over to Dr. Juliet Balfour. Juliet founded the Somerset NHS Menopause Service. She has been a GP for over 30 years. She's a British Menopause Society recognised menopause specialist and a trainer with the Advanced Certificate in Menopause Care. And she also sits on the BMS Medical Advisory Council. She's really well positioned to talk to us about sort of practical tips in terms of starting HRT with your doctor. Over to you, Juliet, and welcome.
Thanks very much, and hello to everybody. I hope you can hear me okay. So yeah, this is going to be a really back to basics as well. So practical advice on sort of how to prepare for your appointment if you want to talk to your doctor about possibly HRT, what to expect during an appointment, and what to expect from your HRT as well, because some people I think have slight over expectations about how amazing they're going to feel. So firstly, preparing for your appointment. So if you're anything like in GP land, 10-15 minutes if you're lucky for appointment. I don't know about in other countries, but it's really worth doing your homework. So read up about the menopause. There's lots of really good resources. Find out about the treatments. Think about your symptoms, and you can actually write down your symptoms, or there's lots of symptom checkers you can get from the internet. And I suggest you explain what you're hoping for at the beginning of the consultation. And it's all about both you as the patient and the doctor joining the dots to work out what's going on. So making the diagnosis, as Vikram's already said, it's a clinical diagnosis. So we don't usually need hormone blood tests unless you're under the age of 40. Your GP might decide it's worth doing some other blood tests. So because there's lots of other conditions that can give similar symptoms to the menopause or can start in midlife. So they might want to check your thyroid function, check you for inflammatory diseases, or check you for anemia or something like that. But there's no point them checking your hormone levels. You might need an examination. So usually before we start HRT, we like to know your blood pressure. Now, the modern HRT we give with estrogen through the skin doesn't actually increase your blood pressure, although the oral slightly does, but it's just really good practice to get your blood pressure done whenever you can, because a lot of midlife women have high blood pressure and it's been undiagnosed, and it's a very important marker of future disease. And we also like to know your height and weight so we can work out your BMI, because that will affect which HRTs we can offer you safely. So if you've got a telephone consultation, get your blood pressure done at your local pharmacy, get your height and weight done so that you can give your GP that information. If you've got lots of vaginal, vulval, or urinary symptoms, so vagina's a bit inside, vulva's on the outside, you may need an examination at some point just to check what's going on and make sure there aren't other things going on apart from lack of estrogen. So HRT. So as Vikram said, it is the most effective option for symptoms if you're struggling with them and you don't have any medical contraindications and you want to take it. And we know it's got very definite proven benefits for bone health and lots of other possible benefits as well. So your GP is going to want to work out, is HRT the right option for you? And they're going to want to know about your medical history and your family history. And with everybody, it's very much an individual assessment to discuss your benefits versus your risks. And for most people, the benefits will outweigh the risks, at least for the first 5 years of use, as long as we choose the right sort of HRT for you. And it is very important if you have POI or early menopause, if you remember, so that's menopause under the age of 40 or under the age of 45, it is very important to consider having HRT if there's no medical contraindications, at least to the average age of the menopause. Because unfortunately, if you have deprived of your estrogen much earlier than the average woman, you are actually at risk of getting thinning of the bones and heart disease and possible cognitive issues. So people under the age of 45, HRT really is a really good idea unless there's a reason not to have it. Now, if you've got a really complex history, your GP might not know whether you can have HRT or not, so they might have to refer you to a specialist clinic. We have got NHS specialist clinics dotted around the country, but we haven't got enough of them, unfortunately, but hopefully you can find one. And in some cases, the oral HRT, oral estrogen, that's actually medically contraindicated, but you can have transdermal HRT, and that's similar. That's for things like if you have high blood pressure or migraine or heart disease. Often one type of HRT is okay, but another type isn't. So then we go on to which HRT is right for you. So then we decide, yes, would you like oral for the convenience, or would you like transdermal? And for most people, we go for transdermal nowadays. And then we have to think, do you need the progestogen to protect the line of the womb? And then there's a few women who've had hysterectomies that still need progestogen, so that has to be decided. We also have to think, do you still need contraception? So some people forget that potentially you need contraception up to the age of 55 unless your periods have stopped for a long time. And that's when the Mirena coil is a really good option, because that can be your contraception, it can reduce heavy periods, and it can be the endometrial protection part of your HRT. Then we have to think about the starting dose. So the general rule is start low and go slow. And some people possibly who are older or got a complicated medical history will start very, very low, and actually a very, very low dose. And we usually start at a dose and then review at 3 months. We try not to increase the dose too quickly because it can take a while for the effect to start. But we certainly don't want to start at a really high dose, because then it doesn't give us anywhere to go. And once, if you are stable and doing well on your HRT, we do suggest an annual check with your doctor to see how things are going, check the bleeding patterns is expected, check your blood pressure, and look at your general life. So what do you need to know when you're starting HRT? So you need to know how to use it. And if your GP hasn't told you, you have a look at the information leaflet. You need to know the common side effects, because a lot of people do get side effects just to start with. And that's another reason for not starting with a really high dose. And we've talked about looking at your benefits versus risks. It's worth knowing that in the perimenopause, when your hormones can be fluctuating really quite a lot, can be quite difficult to get you on a suitable dose, because your dose might be fine sometimes, and then your ovaries kick in with some more estrogen, and then you're having a bit too much estrogen, and you might feel a bit anxious and a bit weird. So perimenopause is quite a tricky time. We can make it a bit better with HRT, but maybe not perfect. And so it can take quite a while to find a suitable product for you and the right dose for you. And with time, your requirements might change. And as Vikram said, there's no arbitrary time limit. It's an annual look at your individual benefits and risks. When will I feel better? Well, the hot flushes and sweats often go quickly, but others can take longer. But it can take up to 3 months, as I said, to get the full effect of a dose. And if it's not helping, we must think, have we got the right diagnosis? Are there other causes? Are there contributory factors? And in particular, it's so important to think about your lifestyle. And if, and it's a big if, a trial of testosterone is indicated, it's really important that your HRT is optimized. And if you have got any vaginal, vulval, or urinary symptoms, that they need to be treated, because the last thing we want to do is improve your libido, and hey presto, sex really hurts. So lifestyle, quickly, you know all this: nutrition, movement, sleep, reducing stress, stopping smoking, and reducing or stopping, ideally, alcohol. So they are so important, whether you're going on HRT or not. We all need to think about that. So a quick bit more about local vaginal estrogen. So it's for these vaginal, vulval, and urinary symptoms that you can get due to lack of estrogen. We call it the genitourinary syndrome of menopause, or GSM, because it's a bit of a mouthful. And these symptoms can actually develop around the time of the menopause or much, much later. Some women don't get these problems till they're 60, 70, or 80. But the problem is, once you get these symptoms, they're only going to get better worse with time. So most menopausal symptoms, you get out the other end. But any of these symptoms, once you start getting them, unfortunately, they're going to just gradually get worse and worse. And figures vary, but we probably think up to 80% of women might get some of these symptoms at some point, and they can really impact people's quality of life. And unfortunately, GSM is underreported. Women are embarrassed to talk about it, underdiagnosed, we don't ask about it, and undertreated. So it's very important to think about this, because local estrogen is safe for almost everybody. You don't need endometrial protection. The women with breast cancer can have some of the products. A bit more complicated if you're on an aromatase inhibitor, but you can talk to your oncologist. And if you develop GSM and you're not going on to HRT, you need to use your local estrogen forever. And at least 20%, probably more, of women on systemic HRT actually also need to have the local vaginal estrogen as well. And we know it is safe to use long term. Just mentioning, for those who don't want to go on HRT or can't go on HRT, we do have non-hormonal options to help, particularly with the hot flushes and sweats. And there's a new class of drug that's coming to help with hot flushes and sweats. I think you've got it in America already. You can get it privately in the UK at the moment, but we're waiting. NICE is looking at it, and hopefully it's coming to the NHS soon. And we also have really good evidence that CBT-I, so CBT for insomnia, can help with insomnia. And specific course of CBT for menopause can also really help. So it's important to remember there are other things apart from HRT. And yet again, as I said, the lifestyle modification is so, so important for all of us. So that's it. I've got 24 seconds left. Woo! So that's it. Thank you for listening.
Juliet,
Well done,
thank you.
Juliet.
That was absolutely brilliant. Really, really fantastic, and so practically useful as well. It's so important, isn't it, to prepare people for their consultation so they get the most out of those sort of 7 to 10 minutes that you have with your doctor. So thank you for that. Joyce, over to you for our last speaker.
Thank you, Shema, and very welcome, very early in the morning, as I've said already, for Dr. Jen Gunter, who is an obs and gynae. She's a pain medicine physician and two-time New York Times best-selling author. And her books include The Vagina Bible and Menopause Manifesto, and her latest book, Blood. And she is very outspoken on social media, which is why I love having Jen for discussions. So I think she's going to rock the boat a bit. And just to say, there's lots of great questions in the Q&A. So keep going, everyone, and our team will have a look at those. Jen, you should be able to share slides now. It should be enabled.
Let's see how that, there we go.
Thank you so much for getting up so early.
Oh,
Thank
my
you.
pleasure. Let's see. There we go. So you're not seeing my messy desktop. There we go.
Thanks.
All right. Is that work? Everybody can see it? Okay, great. And we're well, thank you, everybody. I'm really happy to be here. Yeah, it is early for me, but that's okay. I usually get up pretty early anyway. So this is my motivation. I'll go for a run before I start my day. So there we go, right? Some self-care. So I'm going to talk about some of the things that people might hear about online, some of the things you might hear about in the news, and some of the things that, you know, make those of us who are really interested in giving you the highest quality evidence that make us kind of cringe a little bit. And I think I have 10 minutes here, so I'm going to try to bring it home. So I think the one that comes up a lot is that menopause hormone therapy can prevent dementia. And we don't have good quality data to support that at all. The bulk of the evidence does not support menopause hormone therapy for that indication. And I know that for many people, that's going to be counter to what they've heard in maybe the news or from some people who are high profile. But what can we tell you is that this is what the evidence shows. If the evidence did show that MHT was fantastic for prevention of dementia, it would be in every guideline. So there isn't a single physician who has found science that all the people writing the guidelines haven't found. I think that's a really important thing. And at the Menopause Society meeting this year, we heard Dr. Pauline Mackey, who's like one of the world experts in brain health, walk through all of the research. Now, there is a subgroup of people who potentially might benefit. We don't have the data for sure. And there's a lot of work looking at people who suffer a lot from hot flashes and night sweats. That are they the ones who are perhaps at increased risk for dementia? And there's some data to suggest that. We don't know why though, right? We don't know if people who have more hot flashes and night sweats have a different vascular system, and that also puts them at risk. We don't know if there's a genetic link. We don't know if it's cause and effect. I think that's a really important point to make. However, these are also the people that we recommend treating, right? So if you have hot flashes and night sweats, we recommend treating you. So this shouldn't change your approach at all, because we recommend treating you. And I think it's really important that you also understand that there isn't any data to show that when we're talking about treating you, that estrogen would be superior for your brain health versus something like a neurokinin 3 inhibitor, for example, or cognitive behavioral therapy. Because if we believe that the sentinel event that might be harmful is actually the hot flash, then it doesn't matter how it's treated. And, you know, there is some really elegant data that was presented and which, you know, known about for years, was published years ago, looking at a nerve block to treat hot flashes. And that actually improved people's outcome on memory tests, right? And that didn't have estrogen in it. So just be wary of people who are telling you to take menopause hormone therapy for prevention of dementia, because that's not evidence-based. The evidence has all been reviewed, and all of the Menopause Society guidelines, International Menopause Society, British Menopause Society, Menopause Society from the US, and Australasian Menopause Society, they're all in agreement. And I can't stress enough how difficult it is to get that many doctors around the world to agree on one thing. There are really few things that every single person is like, yes, yes, yes. So that's what I have to say about that. Okay, the myth that bioidentical, or I know in the States, in the US, you use the term body identical, is better and safer. So these are marketing terms, and they might be ways to explain things, but they actually aren't great terms. And they lead to a lot of confusion, because what happens is people hear the word body identical, or they hear the word bioidentical, and they assume that makes it safe. And that is not correct. You might have also heard people say that hormones aren't drugs, so that makes them safe. That is not true. Anything you're taking as a medication is a drug. If your ovaries are making it, sure, it's not a drug. But I can take epinephrine, something made by the human body, and give it to you and give you a heart attack and kill you, right? I can give you high levels of estrogen and give you endometrial cancer. So hormones are medications, they're drugs. That doesn't make them safe or unsafe. It just means they're drugs and they need to be treated as such. So the idea that taking something because it's the same as what your body makes is safe is, again, marketing, and that isn't correct. I personally believe women are smart enough to know that estradiol is the main estrogen made by the ovary, and that's the one that we generally recommend replacing. And so I think people should learn that word. They should learn the word estradiol. Then you don't have any of that marketing that's attached to it, any of that insinuation that it's better or safer. And I just like to remind people, because sometimes in the States, bioidentical gets kind of confused with compounded or used in different ways that it's like not made in a lab. Every single estrogen that you get with the exception of Premarin is made in a lab. It's all made in a lab. It's all made from soybeans that go through a multi-step process exposed to all kinds of nasty chemicals to break chemical bonds and convert diosgenin or another compound into estradiol. So just keep, they're all made the same way. There aren't like doctors who have special estrogens made by people under moonlight with virgins making them, grinding them with mortar and pestles. They're all made in a lab. It's literally the marketing. So when someone's telling you that, oh, you're taking a body identical hormone, that's safer. Safer than what? What I'm prescribing is body identical. It's just, I'm not using smoke and mirrors to sell it. So just keep that in mind. Okay. Many women are poor absorbers of transdermal estrogen. That's like not been shown in the literature. So you can look at all the drug company studies where they look at absorption because they have to get FDA approved and to get approved by, all the agencies. And so we know that sure, it happens. A small percentage. It's not 20%, it's not 10%, maybe it's like 1% with a transdermal patch especially. But the answer when somebody isn't absorbing a product well isn't to give them more of the product that's not absorbing well, because you don't know how much they're absorbing. The answer is to give them a different product that they're going to absorb well. That's it. That's the answer. So I think that's a really important thing. The people who push this poor absorber sort of line, they don't publish what they think their guidelines are. They don't publish which tests should be used to determine it. They don't publish what time of day, any of that. None of that's published. So I think it's really important to keep in the back of your mind that we don't have a level that we're shooting for with hormone therapy. We're giving it to you based on symptoms. But if you happen to be somebody like, say, you've got really bad hot flashes, so you have a symptom that we know should be treated, at least in part, by estrogen, and you're on the maximum licensed dose, then there's one of two things. You're in that small group who's a poor absorber and a patch isn't for you. Move on to a different product. Or there's something else causing the hot flashes. And both of those options need to be considered because it's really rare for someone to get no benefit. So I just like to put that in the back of people's minds. I personally think this poor absorber thing is pushed for people, especially when they have symptoms that really can't be reliably treated by hormone therapy. So for example, we don't have studies that say estrogen can treat brain fog. It can help you sleep better, and that might reduce your brain fog. But if you're looking at brain fog as a standalone symptom, we don't have data to show that, right? So I think people use it as sort of, well, it hasn't improved my brain fog, so I should just push the dose up because I'm a poor absorber. So that's kind of, to me, poor absorber is just, it's not medical. When you ask, I've spoken to people who've spent their whole lives like studying estrogen and how it's absorbed, and they just roll their eyes at that. So keep that in mind. Ultra high doses of unlicensed, just what you kind of call them in the UK, what I would call, ultra high doses are safe. And this would be meaning doses that are equivalent of 100 microgram patch. And so we're not talking about people with primary ovarian insufficiency here, because there are a small percentage of those people who might need a little bit higher than 100 microgram patch. But studies actually show that in that population, 100 microgram patch does really well, because 100 microgram patch gives you the average estrogen that your body would make when you were ovulating. So it really doesn't make sense that someone would need more than the average amount of estrogen that they're making when they're 55, right? Like if that's the average amount you'd make at 40, it doesn't make sense that you'd need more than that at 55. So kind of keep that in mind. These ultra high doses are not studied. So all of the safety data that we have for estrogen can't apply there. I don't know. Is it the same? Does this possibly increase your risk of dementia? I don't know. Could it increase your risk of heart disease? I don't know. Could it have a higher risk of blood clots? Don't know. We don't have the answers to this. So you can't really have informed consent with these higher doses because There isn't consent to sort of tell you, well, we have this data, or we have that data. And something that's really important is we don't know how much progestogen to give you to protect the uterus, meaning, progesterone or progestin, whichever you want to be on. We just don't know. So we kind of assume, and we're like, okay, well, if you're doubling estrogen, we're going to double the dose of progesterone. However, the pharmacokinetics might not work that way, because that might not reflect what's happening at a cellular level. So we don't know, and you're really gambling, with these higher doses. And finally, this whole concept that estradiol levels are somehow valuable in managing menopause hormone therapy. So first of all, they're great money makers, okay? So in the US, I don't know if it's the same in the UK, but the people who talk about levels are the people that charge you for visits. They don't take insurance, right? I'm on salary, which is, I don't know, maybe that's the same as being an NHS doc, but I get paid the same whether I talk to someone about cognitive behavioral therapy, whether I talk to them about hormones, whether I operate on them, whether we sit and chat about shoes because they're feeling better. Like, I get paid the same. So I have no skin in any game, right? I just want people to get better. And in the US, the average doctor seeing somebody for menopause, they may be getting paid literally $50 or $60 for a visit. And that's a whole separate discussion about how that kind of work is undervalued. But so it's not worth it to order tests to have people come back and like reinterpret it for like $20, $30. Like, that's more work. Like, there's just no value in it. So what we see here in the States are people with expensive concierge practices padding their sort of business with doing estradiol levels, whether it's because, well, maybe the cash price to see them is $500 and then you're paying $150 to get your levels tested. Or what we're seeing is you pay $1,500 or $3,000 a month to be part of a concierge practice, and interpreting levels is thrown in. So it's a way to make, because they can't charge they can't give you the same service I give you and make it worth $3,000. Right? Like, they can't, so they have to do something. So levels are not supported by science. None of the studies that look at, estrogen for hot flashes or night sweats or menopause, or for depression in the menopause transition, none of these studies go by levels, they go by doses. We know that very low levels of estrogen protect the bone well. That's a 25 microgram patch. And certainly as you get older, if you want to stay on estrogen long-term, we're kind of thinking, well, if you needed a 100 microgram patch when you're 50, maybe you won't need that when you're 55 or 60, if you're going to stay on it for bone health, because a 25 microgram patch does just as fine. Bone is exquisitely sensitive to estrogen. We're not aiming for physiologic doses. You don't need to have estrogen levels like ovulation. And anyway, when people say, like, what part of the menstrual cycle? When we look at levels in the very first week of the menstrual cycle, they're actually really pretty low, and people don't have symptoms of menopause, right? So that's fine. We're sort of shooting for these early follicular levels. And finally, levels don't tell you the whole picture. They don't tell you what's happening at the level of the cell. So when you take estrogen, a lot of it's estradiol, a lot of it's converted into estrone, which also can have an effect. But if you're measuring an estradiol level, it doesn't tell you what the estrone level is. Sex hormone binding globulin, which is a carrier protein, if that's low, then you might have a higher level of estrogen than you think. And finally, just doesn't tell us what's happening at the level of the cells. So we don't do it for a reason. Again, I'm going to end with the same thing I started with. No menopause society around the world recommends using levels, right? So again, getting every single person to agree on that, like, that's really hard in medicine. Everybody's like, well, I believe this. Everybody agrees on this. So I would say that if people are telling you that you need to follow your levels, you're getting bad advice. And so that is I think I brought it in at 10 minutes. And that's what I've got.
Fantastic, Jen. Fantastic. And I say the same thing. I have it on my slides. Listen to the endocrinologists, the gynecologists, the scientists, and the societies. Societies, when they make recommendations, they spend a lot of time reading everything and understanding, looking at all the evidence. So as you said, for people to agree that they're the ones, don't listen to social media people, journalists, these sorts of people, listen to the experts. So for our wonderful panel, thank you so much. There are many questions, over 40 questions 45 questions in the chat. Some of them are very, very specific. You might feel if there's anything you want to answer, please feel free. But I'm going to hand over to Nicky. Nicky, I'm going to give you 20 minutes. So we're going to go 10 minutes over. So I'm going to hand over to Nicky to ask our wonderful panel some questions.
Thanks very much, Joyce. And thank you very much, colleagues, friends. That was really excellent information. But just to reiterate to those people who have posed questions in the chat, there are a lot. And so I'm afraid I can't get our panelists to answer all of them. And as Joyce points out, some of them are too specific and not suitable for mentioning here. But I've been monitoring them and I've got the general gist. I've also got my own questions. So if it's okay, I think, Jen, seeing as it's super early for you and you want to get off your run, maybe I go straight for you, if that's all right with everybody.
Sure.
And I'll make sure okay. So, Jen, just to, I know you sort of made it very clear, but just to reiterate, because there are still some questions there. So to consolidate what you said, once and for all, we'll just put this to bed, about blood testing and the levels of the blood, of your hormones in the blood, because am I right in saying that every individual woman will have her own personal biological response to a hormone? So even if you have two women, one might have a very low level and feel absolutely fine, and one might actually have what you would think a higher level and feel dreadful. So can you, I know you've said it so many times, but there are still questions and confusion about this, that we know that these are important hormones, but I think also maybe, Jen, it's useful to also reflect on the woman's personal journey up to that point. If she has had problems with PMS or postnatal issues, maybe that's an indicator she personally is sensitive. Whatever that level is, that's how she is for her. Do you agree with that approach? We treat women as individuals, just to reiterate that.
Yeah, so, if you look at, for example, like the normal hormone levels for ovulation, massive range, massive. People can have completely normal, healthy pregnancies with, fairly low levels of estrogen bumped with ovulation. People have perfectly normal ones, very high, right? So, and we don't know, that might have significance for like IVF, but for living your life as it's going, if you're not having any problems, it doesn't mean anything. And so even in the early like follicular phase, there's a range of hormones. The levels do not tell us much about what is happening with you symptom-wise. And I really think that this is hard because there are people with very large media presences who have drummed into the public and to the press that this is of value, and it is not. You do not need to know your levels. You do not need to check your levels. You do not need to do any of that. The only time you need to check is if you are on what would be considered a dose that should be working for symptoms that should be treatable with estrogen. And if your level's like basically in the menopausal range on that, then you don't absorb that, move on to a different product. That's it. But you should not be shooting for a level that is bad medicine. Levels do not tell us what is happening at the level of the cell, and none of the studies use levels.
Thank you. And I suppose the other thing, Jen, following on from that question, is that all the different tissues might have different preferences for what they want. You mentioned that bone is very sensitive. So again, even if we did measure a level, we don't know if that's the one that the brain wants or whatever. So just to emphasize, do you agree that emphasize what you said there? It's got to be on how does the woman feel is the primary thing, and start at a low dose and titrate according to how it goes. Do you agree with that approach?
Absolutely. And as again, though, especially thinking, is this a symptom that can be improved, right, with estrogen? And just again, warning people that once you get into these ultra high doses, what happens is you feel poorly. And then you think I'm not on enough. So then you keep increasing it and then you get into trouble. So if you're feeling poorly on 100 micrograms of estradiol, that means either estradiol is not for you, that's not the treatment for you, or maybe you're in that tiny category of poor absorbers. If that's the case, move to a different therapy. But anybody who's telling you need to keep checking your levels back and forth is not giving you good medical advice.
Brilliant. I think we've covered that one. I think can I have one more question for you? I know you've pointed it out, but again, still some questions. And just to be absolutely clear on what you said, I loved your comparison of imagining someone with a pestle and mortar grinding up some hormones or something, right? So just to put this one again to bed, I hope, from what you said, bioidentical is frankly a marketing ploy, and some of them are not licensed regulated. And actually, we can have body identical here in the UK. We even have them available on the NHS. Wow, prepaid prescription. So we should definitely, of course, it seems natural one would want to choose really friendly hormones that your body's going to recognize, but it's totally possible to do that in a sort of a proper way with licensed HRT or MHT, whichever we're going to call it. We don't have to resort to very expensive, and I think you pointed that out, very expensive usually these unlicensed forms. Is that, have I summarized correctly, Jen?
Yeah, estradiol, which, you know, is body identical, if you want to call it that, but I'm trying to move away from using those terms altogether and teach women we can just learn the name of the hormone. Estradiol, you want the one that comes from a pharmaceutical company, and you can get that in the NHS. On the NHS, you can get it from me for cheap. They're all generics. Like, they're fine, they're safe, they're the ones that you want. And I'll just put in a plug for Premarin, which is made from horse's urine. That's the only natural estrogen, because every estradiol is made in a lab by a process called semisynthesis. But Premarin is the only estrogen that has actually been shown to reduce mortality from breast cancer risk. And so if you have somebody who is at very high risk for breast cancer, high enough risk that maybe you would offer them tamoxifen or baby tam or one of these drugs to lower the risk of breast cancer, but they don't want to take one of those drugs. For me, Premarin is going to be something I'm going to be discussing with them, because that actually, you know, in the WHI, it lowered breast cancer incidence and mortality. And we can combine, I don't know, I think you might have it in the UK as well, but we have it combined with basidoxifene for Duovit, right? So we think that the progesterone component of menopause hormone therapy is one of the drivers of the breast cancer risk. And so, you know, people who are either super sensitive and when they take progesterone, they have bad side effects, or people who are at high breast cancer risk, Premarin is a great drug. And so I just put in a plug for that.
Thanks, Jen. Brilliant. I think I'm going to have to move on because I know Joyce is sort of frowning a little bit to keep in time. So where are we next? So Dr. Vikram, thanks for the excellent talk. So I have a specific question for you, again, sort of synthesized from what people are asking and frankly, my curiosity as well. Talking about you discussed when there is no arbitrary limit to stop taking HRT, but what about when you start it? Because we are in a little bit of a, sorry to give you a really tricky one. It is a bit tricky because officially, we have all the evidence for women who have definitely reached menopause, post-menopause. That's who HRT is for. But I would put to you, and I would be interested to see if you agree, we have this year at least when we're not sure. You're in various states. You could still be in perimenopause. You could be in menopause. You could be post-menopause. So actually, I would argue we could start it then, but actually sometimes it's useful to start even in the later perimenopause. What's your view on that, Vikram, if you could guide us through that tricky one?
Yeah, so I think it fits in with the theme you've been discussing, which is go by the symptoms. I think HRT is a treatment for symptoms. And if we stick to that and say, this is not a treatment simply for long-term health condition, it's a treatment to improve your quality of life. So whether you're in early perimenopause, late perimenopause, still having a little bit of menstrual activity, still having irregular cyclical periods, or you have completely stopped, I think the symptoms will then determine whether you consider HRT as an option. Because in a way, if you look at it, if you look at perimenopause, at some point you will stop and you don't know when that is. And from that point on until the 1 year, those 12 months, you could come up with a bleed any point. You're still in perimenopause. It's only when you reach that 12-month point, you will know I've completely stopped. And all HRT has been studied and licensed, as you say, in postmenopausal women who've been more than 12 months since their last period. So the best way to go is treat the symptom. If at any point during the journey, starting from early perimenopause to late to post, you're having symptoms which are starting to impact you, you've considered lifestyle, you've considered non-hormonal, and you think HRT is the one that actually works, sometimes even with a trial of 3 to 6 months, because some women try and go back. They say HRT wasn't the solution, but for others, HRT may transform it. And so you do that, and that is what the symptom relief will guide you whether you continue or not. So I guess the focus is symptom, symptom, symptom.
Brilliant. We're back to that, so I hope that's helpful. Dr. Juliet, so you're a GP, and this is a question from the chat. Not my opinion, by the way, but just putting it there. You know, some people are saying that there is a problem finding a GP that says they're confident helping you. I mean, I want to unashamedly give a plug for the excellent new course that the British Menopause Society has produced for doctors. I've done it myself. I did their original course and I've done the new updated one. And I think that, you know, and it's virtual, so even GPs living in remote places can access it. and it's pretty thorough and it's quite long and you have to answer questions and it's quite, you know, challenging, but actually you do feel a lot more confident after that. But I wonder, from your point of view, obviously you are a specialist in menopause, a GP, so I guess, you know, I'm preaching to the converted, but what would your advice to women be? And you've given an excellent list of things for women to go and present to their GPs, but I suppose, how do you respond? I partly responded from my opinion, but how do you respond to that often said, oh, there isn't a GP that understands HRT? I mean, what do you say to that?
It is a problem. I mean, we've got it's so variable around the country. So we've got more and more GPs who are doing the basically everyone needs to know the basics. You know, whether it's gynecologists, urologists, endocrinologists, GPs, nurses, everyone needs to go know the basics. But we've got so many GPs doing extra menopause training in lots of different ways. So, but some people are unlucky, and there's nobody who's got a particular interest in women's health, and nobody who's done extra training. So there are areas that where people can struggle to get help. And we still have, you know, we talked about this, the study, the Women's Health Initiative, all these years ago. There's still doctors who remember that study, still think that HRT is dangerous, don't want to prescribe it. And if you're in a practice where everybody thinks that, it is really hard. So that's where potentially the specialist menopause clinics come in, but there just aren't enough of them. So I really do understand some women feel stuck. But then the trouble is they go on social media and they go on these groups, and then other women are it's a real worry, because if women aren't getting help from their GPs, they're advising each other on what to do about doses, and they're saying, oh, increase your estrogen, reduce your progesterone, do this, do that, stop your progesterone, all these sort of dangerous things. So we have got to do better, but we are working really hard at it. So that the new course you talk about, the British Menopause Society one, that aims to give you the confidence to deal with kind of 95% of menopausal issues. And so that we hope that people who do that course can then sort of be the expert in their practice, or they can be the expert in the local area, or in a women's health hub. And there's lots of people like Vikram Vikram sort of trains loads of doctors to be menopause specialists, and he does loads of education for clinicians, as I do. And there's lots more people trying to do that. So it is getting better, but we're not there yet. And I completely understand that.
So for the woman struggling, like someone in the chat said, she's in a remote area and the GPs are saying we don't know anything about it. I mean, the advice, I suppose, would be, while we're waiting for the GPs to do the menopause course and whatever, you know, where are you looking for your sources of information? I mean, hopefully the InTune that Joyce highlighted at the top, that's going to be one source. But at the moment, you can definitely, the NHS website is actually pretty good, you know, and same for the British Menopause Society website and the Women's Health Concern, that's the patient arm of that. Vikram showed a slide with the breast cancer risk. It's actually very, you know, nicely presented, easy to digest. So I think the message we're all saying is, please don't look for your information sources on you know where, social media. Please look at these reliable sources, and hopefully the InTune will help. And then you can go in as that informed patient, and you can help the GP, you know, go in and say, well, I've read this on the British Menopause Society, hold it up, and you know, there we go. So maybe being that informed patient is a good advice. Now, do I have time for one more quick question, Joyce? Is that all right? Yes, no, she's saying one more. Right, one. Okay. To both of you, I suppose, that today, well, on Friday, it's going to be World Menopause Day with the focus on HRT, and that's what we've obviously been focusing on. But Juliet, you did mention it in your talk, but I would be interested to hear your view on this. I think sometimes we do want a quick fix. Everyone does. And you hear about HRT, oh, you know, it's going to be wonderful, amazing, going to make me feel 21 again. I wish. And it's going to prevent all these things later on in life. It sounds like, wow, this is brilliant. But actually, sometimes I feel that we forget the basics, you know, of the lifestyle. I know, Juliet, you mentioned that, but maybe if you could just give your comment on where lifestyle fits into all of this. Open to both of you. Juliet first, because seeing as you mentioned
the most important thing for everybody, whether they go on HRT or not, whether they're struggling or not. So yeah, absolutely eating the right food, trying to get reasonable amount of sleep, I would say movement or exercise, really important for midlife women to be doing weight-bearing exercise to help their bones, and then exercise to get your heart going, but also really important strength training or resistance training. That is so important for midlife women. And that can be heavy gardening, yoga, Pilates, or, you know, weights, resistance bands, going to the gym. But everyone in midlife needs to be starting to do that. That will help protect your bones and your muscles as you get older. Heaven forbid, help you get off the floor when you trip over when you're an old lady. Also helps with our metabolism so that we will have a bit less of that midlife bulge. Exercise, what else I've talked about? Yeah, reducing stress, not sitting, scrolling on our phones, not at the computer all day.
Yeah, especially don't look at social media for HRT advice. Please don't do that.
Absolutely.
So
yeah.
These are really important, and these are things that everyone can do. Vikram, just to quickly turn to you on that topic. I know, you know, we're all we're doctors and we know that HRT and we want to explain that, but actually sometimes maybe we should start off that conversation with the lifestyle, because ultimately that empowers the woman. It's like, okay, I can do something for myself here, as it were. And yes, maybe HRT is an option, and it will probably help synergistically if you've really addressed those lifestyle factors. Do you agree with that, what Juliet's saying?
Absolutely. Juliet has already completed all the answer there. But just to say, HRT has its indication, works well for those indications for some women, but there's no compromise on lifestyle. Whether you are on HRT or not, the lifestyle will underpin everything, and on top, the HRT will give you the benefits if it's meant to give it to you. So no compromise there.
Brilliant. Juliet, you've got another point.
Yeah, one more thing. People say, oh, lifestyle, here we go again. But
I
often find if women are really struggling, so if you're not sleeping, you're aching, your joints are aching, you're embarrassed about your body because you put on weight, you're pissed off with everybody, you're sweating when you move, you're not going to feel like doing all the lifestyle stuff. So I often find then if you get people on the right HRT, they're motivated, they get their mojo back, then they can do all the lifestyle stuff. So that's sometimes the way we have to do it if people are really struggling.
So it's a synergistic, both of these things. These are tools in the toolbox that people can reach for. So Joyce, I think I better wrap it up and pass it back to you.
Nicky, that was perfect and brilliant. And I'm so glad that you brought in lifestyle. Really, I'm obsessed with, like, I think all of us that work on InTune are obsessed with lifestyle. I've just done 2 classes this morning already, and I've eaten very healthily. And I know I've been looking at the chat, and I know a lot of people are asking some questions that the speakers I felt had made very clear. And I know that the speakers, who are all excellent evidence-based clinicians who I really admire, that's why I asked them to come on. I know they're saying some things that you might have in your mind that you've heard on social media, and it's contrary to what you've thought. Please listen to them. These people are the experts, and they really have told you the correct information. So you know, some of the things you don't need to check your hormones unless it's very specific. Preventative medicine, they all said the same thing. So just please listen to the experts, listen to the societies. And I will be putting this on YouTube. I will advertise it on social media as well. And before, I'm just going to hand over to Shema for the last word, but just to say, we are, with our InTune project, trying to make sure that everyone understands about menopause symptoms, treatments, etc., with evidence-based medicine. And some of the people here, Vikram and Juliet, are both part. They've done some research, some educational resources for our project, our InTune project. We've got the UK leaders involved with this. It's a very collaborative project. So bear with us. It takes us time to produce this educational tools for you, but we want to make sure that everyone has the correct information. So please listen in. And almost everyone has been on my podcast. I've got to get Juliet and Nicky on next year, but all the other speakers today, Susan and Jen, they've all been on my podcast. So a really shameless plug for my podcast. You can hear what everyone thinks about menopause on my podcast. So I'm going to hand over to Shema for the very last wrapping up word.
Thank you, Joyce, and thank you, Juliet, to Vikram, to Susan, and to Jen and Nicky. Thank you for really, really expertly coordinated Q&A session. And finally, a thank you to all our participants. I think at its peak, we had nearly 200 people join us, and I'm sure we'll have people who listen in afterwards. I know we didn't cover all your questions. The clinicians who've spoken will not be able to answer questions in terms of individual medical advice. We're just not licensed to provide advice remotely. So if you do need any medical advice, we'd all urge you to go and speak to your GP or another doctor. I realise that that can be difficult at the moment. And finally, just to say, watch this space. We are hoping to make InTune the go-to place in the UK for menopause education and menopause support. We're working on it. I know that there's a huge need and our team are passionate. So bear with us. We will get this done. And I think we'll end it here. Thank you, everybody. I've learnt so much, as I always do when I listen into these webinars. And happy World Menopause Day. Go out there, talk to everyone you know. If you have daughters and sons, tell them about menopause. Let's make sure that the next generation is much better prepared.